Welcome, and thank you for joining me today. My name is Crystal Dorbeck, and I'm currently a student in the AGACNP program at Hawaii Pacific University. Today, I'll be presenting Grand Round's case on a 76-year-old female with heart failure with preserved ejection fraction, who presented with an atypical non-STEMI. This case exemplifies the diagnostic and treatment challenges seen in females, and especially elderly females, with overlapping cardiac conditions and highlights the importance of a multidisciplinary approach. So let's break down each learning objective. To start, we'll look at how women often show unusual symptoms of acute coronary syndrome, such as fatigue, shortness of breath, and nausea, rather than the typical chest pain a lot of times seen in the male population. Recognizing these symptoms is so crucial because oftentimes it delays the diagnosis and can lead to poor outcomes in this population. Next, we're going to look at non-STEMIs and heart failure with preserved EF exacerbation. Although these conditions share some common symptoms, they need separate treatment plans. We'll discuss how clinical reasoning and diagnostic tools can help distinguish between them. Third, we'll develop a comprehensive care plan that brings together experts from cardiology, primary care, nursing, case management, and rehabilitation. This collaborative approach guarantees that every aspect of this patient's needs are covered. Next, we're going to examine the role of non-pharmacological interventions, in particular cardiac rehab. This is a vital and often overlooked approach for older women recovering from ACS. Finally, we'll merge evidence-based practices with a focus on sex-specific factors. By understanding how cardiovascular disease affects women uniquely, we can then tailor our interventions to achieve better outcomes, especially in this population. So today we have for you Miss J. She's a 76-year-old woman who presented with fatigue, shortness of breath, and nausea lasting 3 days. She reported no chest pain, which complicates the diagnosis. Today, we're going to cover 5 key learning objectives that will help us navigate the case and highlight essential points. The aim is to deepen all of our understanding of how ACS presents differently in women and elderly women, how to consider alternative diagnosis, and how to develop that personalized evidence-based care plan that combines both medicine and non-medicine approaches. Ms. J presented to my clinical urgent care center due to very vague symptoms of fatigue, mild shortness of breath, and nausea. Although her vital signs were stable, the urgent care team performed some preliminary labs and an EKG, which raised some red flags. That prompted us to immediately transfer her to the emergency department for further evaluation. I'm very lucky that the clinical site that I'm at allows practitioners to see treatments at affiliated hospitals in the area, and the particular preceptor that I am working with rounds on in-house patients. So we were able to gather a lot of information for follow-up and really dive deep, and it allowed me to examine this particular client's care after she left us. Upon arrival, when she went to the emergency department, her troponin levels were noted to be elevated and trending upward. This, of course, is indicating a red flag of myocardial injury. Her NT, Pro, BNP, and creatinine were also elevated. Her EKG revealed nonspecific ST changes, not diagnostic of a STEMI, but certainly concerning in the context of her symptoms and her risk profile. An echocardiogram was also performed in the emergency department, and it did confirm a preserved ejection fraction with a grade 2 diastolic dysfunction. This is consistent with heart failure with preserved EF, or HFpEF. So just a quick refresh on what all of these levels mean. Troponin is one of the most common cardiac biomarkers that we're familiar with and we hear referenced when we hear any kind of discussion regarding heart attacks. The troponin is basically indicating any kind of damage to the heart muscle, especially from a myocardial infarction or a heart attack. Her troponins particularly rose from 0.17 to 0.25 in the consecutive first draws. The rising trend is consistent with acute myocardial injury. Combined with her EKG changes and the symptoms, even though they're again atypical, this supports the diagnosis of a non-STEMI. Refreshing what an NT-proBNP, it's a biomarker that is produced by the heart, specifically the ventricles, in response to increased pressure from volume expansion and myocardial wall stretch. It's a precursor to the fragment of the active hormone BNP. So although BNP is biologically active, NT-proBNP is inactive but has a longer half-life. This makes it a much more stable and reliable lab measurement. An NT-proBNP of 3,300 supports the diagnosis of volume overload from heart failure, particularly in the setting of shortness of breath and pulmonary congestion on chest x-ray. Her creatinine being 1.1, creatinine is the waste product that's produced by muscle metabolism. Refresher, it's filtered out of the blood by the kidneys and it's excreted into the urine. If kidney function is impaired, creatinine starts to build up in the blood. A creatinine level of 1.1 may be at or slightly above normal. However, in Miss J's case, with being an elderly woman with lower muscle mass, even a mild elevation can be significant. So if her baseline creatinine is lower, for example, 0.8, a jump to 1.1 suggests acute kidney injury or volume status changes, like dehydration or diuretic overuse. These are specific changes that, even though lab values may fall into a normal range, it's very important that we take into consideration the patient's comorbidities and age. So, quick pathophysiology overview. So, non-STEMI or a non-ST elevation MI results from partial or subtotal occlusion of a coronary artery. This restricts blood flow and oxygen delivery to the subendocardial layer of the myocardium. In contrast with a STEMI, where there is complete occlusion and full thickness myocardial injury, a non-STEMI leads to more localized, but still a serious form of myocardial damage. Although it often lacks that dramatic ST segment elevations we often see on EKGs with STEMIs, a non-STEMI still carries significant morbidity and mortality risk if it's not properly recognized and treated. Biomarkers, as mentioned before, such as elevation of troponins, is key to confirming the diagnosis, especially in cases with subtle or non-diagnostic EKG changes. With heart failure and preserved EF, this involves impaired relaxation and increased stiffness of the left ventricle during diastole. This leads to elevated left ventricular filling pressures and subsequent pulmonary congestion. This condition is particularly prevalent among elderly, hypertensive, and diabetic women. In Miss J's case, she checked all of the boxes here. In postmenopausal women, estrogen deficiency also contributes to this increased vascular stiffness, and endothelial dysfunction, and systemic inflammation, all of which exacerbate the diastolic dysfunction and the heart failure with preserved EF. When non-STEMI and heart failure with preserved EF coexist, as in Miss J's case, the clinical picture becomes really, really complex. Symptoms such as fatigue, nausea, and the shortness of breath can overlap between the two conditions, and the absence of the classic exertional chest pain. This further blurs the clinical presentation. These overlapping mechanisms make diagnostic really challenging and necessitates a real high level of clinical suspicion, careful evaluation of biomarkers and imaging, and really a good nuanced understanding of sex-specific cardiovascular physiology. Our key differential is non-STEMI, backed up by increasingly high sensitivity troponins and non-specific EKG changes. Although she doesn't report the classic chest pain, her cardiac risk profile, including hypertension, diabetes, and high cholesterol, and advanced age, puts her at risk for a heart attack. Notably, older women often experience heart problems without chest pain. So instead of showing vague symptoms, instead they show symptoms like nausea, fatigue, as seen here. However, we also need to consider that her heart failure with her preserved ejection fraction may be getting worse. Her high NT pro BNP levels and echocardiogram results show diastolic function, supporting this possibility. In HF with preserved EF, symptoms such as shortness of breath and fatigue are common, and volume overload can occur even when the systolic function is preserved. Say if she missed her dose of diuretic or had too much sodium in her diet, she might be experiencing mild fluid retention that can contribute to these symptoms. Another consideration is her long-standing diabetes. It also raises concerns about diabetic autonomic neuropathy, which can reduce her ability to detect cardiac ischemia and can cause gastrointestinal symptoms like nausea or early fullness. This another possible cause of her symptoms is diabetic gastroparesis, which is really common in older patients with diabetes. You can see that these conditions overlap, highlighting the need for a wide range of diagnosis when evaluating especially elderly patients, and in particular women. They often have unusual signs and need a full evaluation and understanding, this to avoid missing important diagnosis like acute coronary symptoms and syndromes that can be detrimental. After trending her cardiac biomarkers, specifically that rise in the troponin, and assessing her EKG changes, they did confirm the diagnosis of a non-ST elevation MI in the setting of overlapping heart failure with preserved EF. Her clinical presentation did lack that hallmark symptom again of chest pain, which did contribute to a slight delay in recognizing the seriousness of her condition. This type of silent or atypical presentation is unfortunately common in elderly women, often resulting in underdiagnosed and understanding of acute coronary syndrome. For this instance, she reported to urgent care versus going to the ER, which would have been a better choice in the immediate scenario. In her case, the presence of comorbidities such as diabetes, her heart failure with preserved EF, combined with her age and sex, significantly increased her risk for this atypical ischemic symptoms. These factors further highlight the importance of maintaining a high index of suspicion and using objective markers, such as the ones we've previously mentioned, to confirm cardiac events in patients who may not present with that typical symptom. So the management employed a comprehensive pharmacological approach, of course. She was started on a dual antiplatelet therapy. This consisted of aspirin and Plavix to reduce her platelet aggregation to prevent further thrombus formation. She also was started on statin therapy, which was initiated for a secondary prevention of any kind of cardiovascular effects. Given her volume status and symptoms of congestion as well, IV loop diuretics were administered, very cautiously, of course, but just to help relieve some of the pulmonary congestion, but also to carefully to avoid hypoperfusion, which is especially prevalent and necessary in patients with heart failure with preserved EF. Beta blocker was then started for her for rate control and to help reduce myocardial oxygen demand at a very small dose with follow-up provided. We wanted to make sure to avoid any kind of hypotension or bradycardia, which would be poorly tolerated by Miss J. Cardiology was also consulted early in her hospital course for both medical optimization and consideration of further ischemic evaluation, including the potential for a need for any kind of coronary angiography, depending on involving the clinical picture and the biomarker trends. Due to her age and comorbidities, decisions around invasive testing required shared decision making and risk-benefit analysis. So as you can see, it takes a whole team in order to really see exactly what's going on in this clinical picture for this patient. Of equal importance was the initiation of some non-pharmacological strategies most primarily focusing on enrolling this patient in a comprehensive cardiac rehabilitation program. Cardiac rehab is a critical evidence based component of secondary prevention following an MI and has been proven to improve long term outcomes significantly. It is especially beneficial for elderly female patients who are frequently under-referred despite well documented benefits. For Ms. J, cardiac rehab offers much more than physical reconditioning. It incorporates structured, supervised exercise designed to safely rebuild her cardiovascular endurance, which is particularly important given her baseline frailty and comorbid heart failure with preserved EF. In addition, the program offers individualized lifestyle counseling that focuses on modifying certain risk factors, including smoking cessation, tight control of her high blood pressure, diabetes management, and lipid control. Nutritional education is a key element here, helping her make heart-healthy decisions with her food choices and limiting of her income of potential dietary restrictions. It also provides psychosocial support, which is integral to the cardiac rehab and success of Miss J. She does live alone and has very limited family involvement. This places her at even higher risk for depression, social isolation, and poor adherence to any kind of program that she's given. Through different types of counseling services, group sessions, cardiac rehab helps address these emotional and behavioral components, improving both of her engagement in care and overall quality of life. Research, including an extensive Cochrane review, demonstrates that cardiac rehab significantly reduces the 1-year mortality and hospital readmission rate, making it a cornerstone of post-MI recovery, especially in this instance with Miss J being elderly without a lot of support to wrap around her in order to see her successful. According to Carr and Lau, women are more heavily impacted by heart failure with preserved EF, especially in older age groups. Their study shows that women not only have a higher rate of heart failure with preserved EF compared to men, but they also tend to show up later with symptoms due to the unusual presentation or mild symptoms, such as Miss J had, like fatigue, shortness of breath, or stomach problems. These are often mistaken for other causes. These unusual symptoms, again, often result in prolonged delays in diagnosis and treatment, which can, of course, worsen long-term outcomes. These researchers also investigate the underlying biological mechanisms that make women more vulnerable to cardiovascular issues. In particular, women that are postmenopausal tend to have stiffer arteries and weaker ventricular relaxation. This, in turn, increases the pressures in the left ventricle and leads to the development of heart failure with preserved EF. Furthermore, women have more severe inflammatory and scarring responses in their heart tissue, adding to the problems with relaxation during the heart's filling phase. These differences highlight the need to consider sex-specific factors when diagnosing and treating cardiovascular disease, especially in older women, to ensure, again, timely and effective care. These 3 studies underline the rationale for our management. Maida et al. And their scientific statement from the American Heart Association provide critical insights into the sex-specific disparities in presentation, diagnosis, and treatment of acute MI. They emphasize that women often present with non-chest pain symptoms, such as, again, nausea, fatigue, and dyspnea, which frequently leads to under-recognition of ischemic heart disease in this population. The statement calls for heightened awareness and tailored clinical approaches when evaluating women with a potential acute coronary syndrome. Their findings are particularly relevant to Miss J's case, as her atypical presentation led to a delayed recognition of her non-STEMI. The article advocates for more inclusive and sensitive diagnostic framework, reinforcing the importance of our decision to pursue cardiac biomarker trending, advanced imaging, and early cardiology consultation, despite the absence of the classic symptoms. Anderson et al. Provide strong evidence, again, for cardiac rehab as an intervention to improve outcomes and reduce hospitalization rates. Unfortunately, Miss J's psychosocial context added to the notable complexity of her overall management and recovery. As her being an elderly woman living alone, she lacked a consistent caregiver support and demonstrated limited insight into the severity of her condition. During our interactions, it became apparent when we saw her for follow up in the clinic afterwards that her health literacy was really low. She was unsure regarding some of her medications, the purpose of recent diagnostic testing results, and the implication of her symptoms. These factors are scary, and they really increase her risk for poor medication adherence, missed follow up appointments, and potential readmissions or having a recurrent MI. Recognizing these challenges, we did implement a multidisciplinary support plan. Social work was engaged to assess her living situation, coordinate transportation for her follow up visits, and also exploring some community based services such as home health support for someone of her age. Case management did work to help facilitate smooth transitions of care, including arranging her cardiology and cardiac rehab referrals. Pharmacy also conducted a thorough medication reconciliation before she did leave the hospital and provided her with some education on her new prescriptions as well. When she was in our office, they do an amazing job of supplying printed education materials and really helped her go through and arrange her medication so she knew exactly what she was taking and when. Addressing a lot of these barriers was essential in really developing a safe and sustainable discharge plan that prioritized her independence while also reducing the risk of decompensation and readmission. Follow-up included a structured and staged approach to ensure the continuity of care and early detection of any recurrent cardiac events. Serial troponin measurements were continued in the hospital, of course, to confirm stabilization of her MI. She had several repeat EKGs to assess for any kind of evolving changes. She was also scheduled for an outpatient echocardiogram about 4 to 6 weeks post-discharge to reassess that left ventricular filling pressure and also evaluate the progression of her diastolic dysfunction, which is especially important, again, managing her heart failure with preserved EF. To evaluate for any ongoing or residual ischemia, a non-invasive stress test was ordered for her in order to follow up. This would also help guide our long-term medical therapy and determine if further intervention was needed. Additionally, she had very close outpatient follow-up with her primary care provider, which in turn is our urgent care for her, and also follow-up with her cardiologist was emphasized and coordinated. Giving her living situation and limited support system and a potential again for the low adherence, these visits were really a big deal for us being able to monitor and make sure that she was getting the proper care that she needed. Also reinforcing medication education and making sure that the cardiac rehab visits were happening. Her high risk for decompensation due to her age, heart failure, and atypical symptom profile necessitated our proactive surveillance and patient-centered coordination. Unfortunately, we all know that healthcare disparities persist and are particularly pronounced in cardiovascular care, as mentioned, for women. There's been numerous studies, including those by the American Heart Association, that have demonstrated that women, especially older women and women of color, are significantly less likely to be referred for cardiac rehabilitation despite equal or greater potential benefit compared to men. This under-referral is compounded by systemic issues such as implicit bias, socioeconomic barriers, and limited provider awareness of sex-specific presentation patterns. These atypical symptom presentations, like we've seen with Miss J, are often unappreciated or misattributed to non-cardiac issues, which again delays diagnosis and appropriate treatment and follow-up. These delays contribute to worse short and long-term outcomes for female patients with acute coronary syndrome. Additionally, women are more likely to face logistical and financial barriers that further hinder access to specialty care, diagnostics, and recovery programs. As clinicians, we have to remain vigilant in recognizing these inequalities and take an active role for advocating for our patients. As mentioned before, this includes ensuring that women with cardiovascular disease receive access to these diagnostic tools, therapeutic interventions, follow up care, including enrollment in cardiac rehab. Helping to employ a multidisciplinary approach, bringing together cardiology, nursing, social work, pharmacy, and rehab ensures that the care is holistic and addressing all issues. This can help optimize and reduce all the disparities, improve outcomes for these vulnerable populations. Summary and key takeaway. This case again highlights the need for careful listening, critical thinking, and thorough collaboration. Older women with multiple health issues are particularly susceptible of being underdiagnosed and undertreated. Cardiac rehab is not a choice. It's crucial for long-term recovery. Thank you so much for your time. These references helped with diagnostic and therapeutic approaches in this case. They do represent some of the most current literature and clinical recommendations. I hope that everyone can take away a little bit from this case study in order to help guide and to prevent adverse outcomes in any kind of atypical presentation of heart attacks or any kind of acute coronary syndrome, especially in the vulnerable populations such as women and elderly women. Thank you again so much for your time and attention.